Good morning, everyone. Welcome to another webinar presented by your SWORBHP Base Hospital program. My name is Stephanie Romano, and I'm the Education Coordinator for the Base Hospital. Today we're presenting a webinar on PTSD and supporting paramedics through work-related stress. We're going to present to you some research that was done by some SWORBHP staff, as well as Elizabeth Donnelly, paramedic social work researcher, who will also be part of the presenting panel today. Assisting Elizabeth, we have Pete Morassutti, paramedic educator, and Paul Bradford, who's one of our local medical directors. So if this is your first time doing a webinar with us, which I think all the names on there seem pretty familiar, but if it is your first time, you're going to see a PowerPoint presentation, and you're going to hear sort of a podcast or a voiceover of the PowerPoint presentation, and this is all done live right now. So you're going to hear us talking about the slides as we go through them, but you'll also have the opportunity to ask questions both throughout the presentation and at the end of the presentation. So if you have any questions throughout the presentation, you can use the question box at the bottom of your control panel and just type them through. They'll come to me, and I'll pass them along to the panel so that everyone can sort of hear the question and hear the answer live. If at the end of the presentation anyone has any questions that they'd like to ask live, if you have a microphone, we have the opportunity to actually have you speak during the presentation live so that everyone can hear you. So at the end of the presentation, I'll sort of introduce that, and I'll tell you exactly how to do that. But do keep in mind that you need to have a microphone for that option. So again, throughout the presentation, please feel free to send in some questions using the chat box, and I'll relay them to the panel. Otherwise, I will pass over the presentation to our presenters, and I hope you guys enjoy.
Morning, guys. Can you hear me?
Yeah, loud and clear, Pete.
Okay, perfect. I'm with Dr. Paul Bradford and Elizabeth Donnelly, our stress researcher, and they will start presenting the PTSD and supporting paramedics for work-related stress.
So basically, where this is coming from, this is Paul here. I sort of got interested in stress from my previous career and my experience with the military. And when we were in Bosnia in the 90s, we had a lot of injuries and mine injuries and shellings and so forth. And during that, we had a number of our people. It was quite a small unit. You can know all of the guys that are there. It was like 1,000, or so guys, which kind of over the 6-month period. You train together 9 months, like it's only a year together. There was incidents that happened, and just kind of watching people kind of process some of those incidents when we had guys killed or really badly injured, and including our team. I sort of was interested in how the system supports that. And certainly I remember in one case the Canadian government sending some social workers over to talk to the guys, and that really did not go well. Guys had been there for a while and really didn't connect with them, and that kind of plan, really fell through. And in fact, the social workers became very stressed from their experience of being to travel there and had to be returned home early. So it was kind of, I sort of, looked at that, and then, you're living through that. So you live through that, and you look after soldiers, and you move through that. And then I started working with the base hospitals and the paramedics. And I really couldn't help but see the similarity with paramedics and soldiers, that they just kind of keep going, really don't seek any care. They're kind of, get on with their work and really feel that they're indestructible, from my sense of it. And really very, really very, unlikely to kind of seek care or aid, especially for stress issues. And then through the job, looking at performance, that gradually is built up and has become more encompassing and comprehensive, in that when a paramedic's doing a delegated medical act, and there's a filter and a system we have in place to audit that, and you kind of notice, say a paramedic has been there 15 years, and then suddenly there's a couple of errors in 1 month, which was very, very unlikely to happen for this paramedic in general. And so, that sort of the way our system works, sort of, being that person, hey, what's going on? You had a couple of kind of major errors in the last month, and a lot of the time, the concern was actually of a personal nature. It wasn't necessarily that remediation would help, or basically going over their work or going through the call or sitting back and doing remediation on the defibrillator or the delegated medical access was very helpful. You know, when I sat down with these people and talked to them, it was that, you know, their wife was leaving them, or they had a sick kid, or their mother had just been diagnosed with cancer, or, you know, basically major stressful events in their life affecting their performance. And so I kind of looked at this from a system point of view, thinking, well, here we are looking at remediating people when there's a problem, and, you know, is that the best way to help? And do we need to be more comprehensive, and you know, and this needs to be explored. And then from there, I met Dr. Elizabeth Donnelly at doing some research down the National Association of EMS Physicians and presenting some work there. And she found out she's an expert in this field, having done a PhD in paramedic stress in the United States, and was interested in doing research in a Canadian context. And so we hooked up to the University of Windsor, and we looked at exploring this issue and basically how we can kind of assess this and put some kind of numbers to this and come up with some sense of maybe what's a better way of looking after paramedics and offering them support in Windsor and Essex and Kent and all of Ontario. So what we wanted to do is identify the sources of paramedic stress, and then this would lead to the idea is that you have stress, and then it becomes a problem for 3 to 6 months, and then it's actually post-traumatic stress disorder, right? So it becomes a disorder if you're not able to function, it's affecting your life, and it becomes a disorder. And then describe how post-traumatic stress evolves to become a disorder, and then identify you know, paramedic stress resources. So that's kind of what our goal is, and to really kind of, as a way to walk us through the goal, we're going to look at kind of how we decided to kind of tackle this and explore the issue. There's a number of stresses that paramedics are exposed to, like all kind of healthcare professionals, and it emerges as well, you see it, which can contribute to the post-traumatic stress disorder. So the idea is you end up at post-traumatic stress disorder when this builds up and affects your life. Now, what I used to think was that, you know, you have your critical incident, and, you know, that could be you picked up 2 burning children from a fire or whatever, and that, you know, has affected you on some deep emotional level, and then you go on to not cope or handle that or process that in a healthy way. You walk into this incident with the baggage of your life, who you are, how you were raised, all of those things, and that decides, plus the incident and how you process it, whether or not you get post-traumatic stress disorder. But what I've learned now working with Elizabeth, that in fact we can actually break down the different kinds of stress that people have. And so there's like the critical incident stress of having the event, and then there's the stresses of operational stress, which is like working on an ambulance, which means shift work and in the rain, and you know, those effects of being in a vibrating, you know, traveling vehicle at high speed and possibly sitting for periods of time in the corner in the middle of nowhere, you know, those type of things. And then there's this organizational stress, which is interesting. And the organizational stress is like how your employer, how the organization you work in, how that works and how that supports you and how effective that is. And those 3 things together have an effect on whether you develop post-traumatic stress disorder. So this was new. This was sort of new ground for me in that regard, because, you know, the critical incident stress itself, you could say, well, we can cut down the number of critical incidents by not having 10 paramedics go to the burning children. Maybe in a way we cut down a critical incident because we're now doing tours. So if someone's pulled out of a fire and the paramedics, you know, still warm and they're obviously dead, the paramedics can stop and do a trauma tour at the scene, and so that critical incident doesn't spread to the emergency department where the staff would be affected, if you think about it that way. But the organizational stress we can have an effect on, and then stresses associated with working in ambulance we can have an effect on. So perhaps by quantifying this, we may have a way of helping paramedics have less post-traumatic stress disorder by working on it. So that was kind of the idea, and that was kind of the spirit of our work.
All
right, guys, thank you so much for taking the time to join us this morning. This is Elizabeth Donnelly. I thought I would just give you a brief sketch of where I'm coming from. I have been an EMT in the United States since 1999. I've worked on ALS and BLS services, and actually I've been in EMS a lot longer than I've been anything else. So when I do have a degree in social work, and when I started my doctoral studies, I wanted to look at EMS, and I was sort of stunned at the lack of research. There hasn't been a lot of serious investigation until recently into paramedic stress. There's certainly been research into police stress and some research into firefighter stress, but EMS has been relatively invisible. So it seemed to me that this is something that would be really valuable to look at as I went through my PhD studies. I finished, I got a job at the University of Windsor and was able to translate some of the research I've done in the United States into the Canadian context, which is what we're talking about here. So I think that this is an area that's still evolving. We're still continuing to explore it, and this is really exploratory research. We're just starting to understand how the different kinds of stress interact and how people can be resilient in the face of stress. So Paul already mentioned that there are a couple of different kinds of stress. Stress isn't this sort of giant entity. It's not just one thing. Stress can look a lot like a lot of different things. We already know about critical incident stress. It's something that's been around in our conversations since the 80s. And critical incident stress is a very particular kind of stress because it's related to patient care. It's usually something that's discrete, so it's not something that goes on for a long period of time. You show up at the call, you manage the call, you're done with the call, and then you go about your business and you go on to your next call. And so it's a short period of time, and oftentimes people handle really tough stuff, and they do just fine with it. So, what makes an incident a critical incident? Some of it depends on, how do you react to it. If something happens at that call that is bothering you, that interferes with your ability to do your work, if it interferes with your ability to live your life, then that could be a critical incident. So it's not necessarily what happened, but it's how did it affect you. Some of those things that are the most common as far as critical incidents, responding to kids is something that comes up an enormous amount. Responding to friends or family, or another thing I've noticed just in my work on the street is that responding to people who remind you of friends and family. So if you have kids that are the same age as a patient, or I remember once listening to a partner talk about a woman who'd been hit by a car, and he's like, I just kept seeing my girlfriend lying there. I was like, oh, okay, that's got to be careful there because you're starting to personalize it. That could potentially be a critical incident. Other things that come up as far as critical incidents, elder neglect, someone who's been burned, drowning victims, animals that have been abused. Actually, when I did some research in the U.S., the most commonly cited critical incident was just watching someone die. It's something that can happen not just once a day, but multiple times a day. But if it happens enough, if you start losing more and more people, it can potentially cumulatively become critical. So anytime you're on a call and there's also this sort of, sorry, let me back up for a minute. There's also two different kinds of threat when you're on a call. There's the sort of the immediate threat. So someone can threaten you. You can have someone who's drunk, aggressive, high, psychotic that are just directly threatening your safety, and that can cause critical incident stress. Or just observing someone else being hurt, injured, tragic circumstances can also cause critical incident stress. You have those two kinds of exposure that excuse me, can lead to critical incident stress. So that's critical incident stress. What's this other kind of stress that we're talking about? Chronic stress. All right, so chronic stress is something that exactly what it sounds like. It goes on for days and days and days. It's not the kind of thing that starts and ends, but it's like every time I come to work. Or this is just, this person that I'm working with is driving me up the wall. And it's always there, and so it's not...
I have that. Yeah.
And so, but you think about these relatively enduring problems that you're dealing with, that sort of just, it drags on you, it wears on you, and so it's not this sort of discrete critical organ stuff, but it's more chronic stuff. So when we're thinking about chronic stress, there's a couple of different kinds of chronic stress, and this is just the way I decided to divvy it up in my research. There are other ways to do it. There's organizational stress, so that is stress associated with your organizational culture. All right, so what am I talking about when I'm talking about that? I'm talking about different rules, favoritism within the organization, feeling like you need to prove yourself, constant changes in policy or in legislation, staff shortages, so you have to do a lot of overtime, red tape, lack of training on equipment, supervisors that are on your
Jerk,
case.
I think jerk is the word you're looking for.
Well, sometimes there's always a possibility that some supervisors seem to be on some people's cases more than they're on other people's cases. Lack of resources, people overemphasizing the negative, so people always getting on your case rather than telling you when you do something well. And that can vary depending on the organization. So if you're at one service, you may have a really supportive structure, and that you may have less organizational stress, or you may be at an organization that has a pretty punitive, caustic organizational structure, and that can cause a lot of organizational stress. So you've got these two different, the politics and the environment of your service can really make a big difference in how you enjoy your work on a day-to-day basis.
That's an interesting point, because sometimes I walk into the department, a night shift or emergency, I look at it and there's a certain charge nurse, so I just know everything's going to go great tonight. Like that, there's not going to be a lot of drama, everything's going to be handled. So maybe in some way, some supervisor or some boss's leadership experience or the way that they handle situations basically permeates to everybody, right? And I think we've all had that kind of feeling, right? Or someone else saying like, oh no, this is going to be brutal, right? And so, and maybe that's unfair, right? But that's kind of, I guess it's sort of a tally, right? We kind of add up the number of days that, it kind of affects us on an emotional level.
Absolutely. Absolutely. So that's organizational stress. Operational stress is a little bit different because there are stresses associated just with being a paramedic.
Yeah.
There are certain elements of the job that doesn't matter what service you're at, going to run into that sort of stress. Paul already mentioned shift work. If you're working nights, there's stress associated with that. There's a risk of injury, back injury, getting assaulted, that sort of stuff. And that doesn't matter what service you're at. If you're lifting and you're moving, you're dealing with people who are chemically enhanced, there's always a possibility of injury. Your family is pissed because you're not there, because you have to work, and so they don't understand why you can't be at your son's baseball game, or you can't make this family gathering because
or Christmas
or Christmas
holidays. Yeah, exactly. Oh yeah.
So negative comments from the public, so getting static from people because something happened and it was in the paper and yeah, you paramedics, this, that, and the other thing. So because paramedics are visible and people tend to have opinions about it, you may get that sort of feedback from the community. And just feeling like you're always on the job. I mean, the thing is, a lot of times with shifts, you're sitting there and you're waiting for something to happen, and it's just like, oh my Lord, how long have I been here? And especially if you're doing overtime. In the States, I would have coworkers that would pull 48, 72-hour shifts because that's what they had to do to pay their bills. And so, they're literally always at work. You see your partner oftentimes more than you see your family. And so again, that doesn't have anything to do with the service you're at. It's just kind of the job.
We have this kind of code 7 thing too, right? Where you're trapped in a hallway. You can't use, you can't eat, you can't drink anything, you can't sit down. Like there's a lot of. I think that would be very stressful too. Mm-hmm. And that's sort of a thing that's sort of grown over the years, which we're trying to work on. But I think that's to know that you're going to be spending part of your your shift where you're, looking for some, to do some good and get out there and help the public, and then you're trapped like that. I mean, that's gotta feel brutal.
Well, absolutely. I mean, it's a very helpless feeling.
Yeah.
I mean, you didn't get into paramedicine because you wanted to hang out in a hallway with a patient for 12 hours. You wanted to do good. You wanted to save lives. And so those sort of institutional barriers can be really
It's like,
stressful.
you brought this patient, so you need to be punished or something. You know what I mean? Right? Like, right? Like, and I see that sometimes with the, with the emerge staff. They kind of, well, why'd you bring him here? Well, because it has a giant H on the building, right? Right? It is for this sort of unhealthy kind of to and fro that happens, which they sort of get blamed for bringing the person who's unconscious nightly, back in, right? Which is unfair, and I don't think we reflect on that a lot, though.
So anyway, those are the three kinds of stress that we've sort of identified as being problematic for paramedics. And I just wanted to make a quick point is that, we talk about post-traumatic stress disorder, and PTSD is one of those things that's been identified a fair amount in the literature as problematic, but it's not the only way that stress can manifest. There are lots of other ways that stress can show up in your life. And I just wanted to sort of broaden our scope for a minute and think about, all right, so if I'm not having a post-traumatic stress reaction, that doesn't necessarily mean everything's hunky-dory. I may be cranky with my job. I may have poor physical health. I may get depressed. I may have just be tired and burnt out. So there's lots of other ways that stress can show up in your life. It's not just necessarily about post-traumatic stress. But when we talk about post-traumatic stress, I did just want to be clear about what am I talking about? What do I mean? We use the term PTSD and we kind of throw it around a lot, but I'm not sure the degree to which everyone understands what are the symptoms of post-traumatic stress. So symptoms could include re-experiencing the event. So what does that mean? It's recurrent, intrusive, distressing recollections. So you go to a call and you can't stop thinking about it. It keeps popping up. Things remind you of the call. You're dreaming about the call, and when you think about the call, you start feeling distressed, and that can be sort of a psychological distress. You start feeling upset, or it can be a physical distress, like you start feeling uncomfortable, you start feeling anxious, all those sorts of things around the call. Avoidance of stimuli associated with the trauma, so that's avoiding things that remind you of the event or the call. That could be thinking about it, feelings you have about it, conversations. Avoiding places that remind you of the call, so not driving down that one street where you had the bad call because you just don't want to go there right now.
Smells, too, right?
Sure, absolutely.
Yeah. That's another thing that people underestimate.
You may also have difficulty remembering parts of the call. You may start sort of feeling dissociative, like, I don't really remember what exactly happened. That would be considered avoidance as well. And then persistent symptoms of increased arousal. So if you're having difficulty sleeping, or difficulty falling asleep, difficulty staying asleep, you're getting irritable, you have outbursts of anger, you're having difficulty concentrating, you're really hypervigilant, you have an exaggerated startle response, so you're really easily startled, like if you hear a loud noise. All those things are considered symptoms of a post-traumatic stress reaction. Now, to have a post-traumatic stress diagnosis, you have to have symptoms for at least a month. So if you have something that's going on in your life and it's bothering you, and it's been bothering you for at least a month, then you definitely want to get some further help, get some further consultation, because you're to the point where the reaction may potentially be pathological and you need to get some sort of assistance. The other really important thing about this is that for all of us who run calls, you have calls that bother you. You have calls that you kind of think about a lot and that stick with you. But that doesn't necessarily mean you're traumatized. The symptoms have to be bad enough to interfere with your ability to live your life the way you want to live it. So are these symptoms interfering with your ability to do your job? Are they interfering with your ability to be a good partner or a good parent? Are they interfering with your ability to attend to your responsibilities? That's another really important part of this, is that in order for it to be problematic, it needs to be interfering with your ability to live your life the way you want to live it. I wanted to just also sort of talk for a minute about the difference between post-traumatic stress disorder and post-traumatic stress symptomatology. Like I just gave you sort of the diagnostic criteria for post-traumatic stress disorder, but it's not a black and white issue. It's not a yes or no. It's not you have PTSD or you don't have PTSD. We're human beings, and human beings experience symptoms on a range. It's a continuum. So you can have post-traumatic stress symptoms that aren't necessarily pathological. You may not meet the criteria for a diagnosis, but you can still become impaired. So even if you're not quite to the place I just outlined, still paying attention. If you do have those symptoms of avoidance or hyperarousal or intrusive and recurrent dreams, those are post-traumatic stress symptoms, and so you need to sort of be attentive to that and say, all right, so this is something that's happening, and there's probably a reason why it's happening. Not everyone needs treatment. We are a resilient bunch. People who go into paramedicine often know that they're going to be exposed to tough stuff, and so oftentimes symptoms will resolve on their own. You don't always have to go and see a shrink every time something happens that bothers you, but it's a matter of paying attention and saying, is this a problem? Is this interfering with my ability to live my life? The key is to be aware of what's going on and to take care of yourself. So that, I'll get off my soapbox about that. But I just wanted to be real clear that when we're talking about it, it is a continuum.
So basically we're going to try and get some idea about modifying the concept of PTSD. And Stephanie just sent me an interesting stat that just came out that statistics show that in the beginning of the war in Afghanistan, over 2,600 American soldiers have committed suicide compared to 2,000 who died fighting. And the reason is post-traumatic stress disorder cases now surpass the number of combat deaths. So that's certainly the Canadian experience. Usually when you look at the number of deaths in theater, you can multiply that by 10 to get the number of injuries. Mm-hmm. And generally, if you can make it to the trauma hospital in theater, you got like about a 98 to 99% chance of surviving that. But then, many of our people are suffering later, and I think it's sort of the hidden mortality, right? That goes on for years afterwards, and I think we see that with paramedics as well, and it's very difficult to, I think, study this kind of thing. So
yeah, just to sort of follow up on that thought, I think that the key with, I think, soldiers and paramedics is to be willing to acknowledge what's going on and to be willing to ask for help. I think that oftentimes we paramedics give ourselves the message, and I remember this quite clearly. I had a partner once who said to me, if you can't take it, you're just a pussy. Yeah. And I remember thinking, golly, that is a really powerful message for someone who's maybe 18, 19 and just getting into paramedic practice. So if someone's hurting, if someone is in trouble and they hear that, what are they going to do? Are they going to be willing to ask for help? Are they going to be willing to talk to a friend or to a partner and say, hey, this is bothering me? Or are they going to shut up? Are they going to go get drunk? I mean, we have to be careful in the message we're giving ourselves about the degree to which we give ourselves permission to be human.
Yeah, I think paramedics, when they're in the uniform, they're in that, like, they're good to go. They're ready to go out there. And I think they take pride in that.
Yeah,
I agree with you. I think there's a peer pressure to be good to go and go do your job, right? And I think we have to kind of look at it as a profession that we have to look after each other, we have to look after ourselves, and I think that's hard. It's hard to make that change, right?
Mm-hmm. Absolutely.
When you're saving lives and stamping out pus and disease in the middle of nowhere in the middle of the night, right? Like, I think the whole concept of the stress thing, when you think about it, if you're going to study that, you're going to try and somehow get a handle on, if you want to make a change, you want to improve things, you really got to get a handle on basically what the current situation is and get some quantification numbers around it. Because you can go up to bosses and higher ups in the government and say, well, this needs to change. Well, you know what? Yeah. Right? But what you need to do, though, I think, is say, well, we've got these numbers and this quantification, and this is kind of what it seems to show, and we'd like to try this, this change, this specific change, or this change, right? And so, with that in mind, Elizabeth helped us work out some research objectives, and in this case, we worked with the service in Essex, Windsor, and basically look at somehow studying this concept and putting some ideas around that. And so we looked at the different types of occupational-related stress may contribute to stress reactions for paramedics, and also the determine how paramedics. So basically, when a paramedic has stress, what do they do with it? And so we basically looked at, it was a questionnaire, and then we had a prize. We had like an iPod as a prize, right? And if you filled out this thing, you got, and it was our first real kind of survey. And personally, I'm not really keen on surveys, right? I'm going to probably get one every other day that comes to me an email. But and this one we did like online. But we thought, this is really focusing on the paramedics themselves. So we we were pretty lucky. I think we had a fairly good response rate. And I think most people were. I don't think there was any weird answers that someone just hit every button or whatever to get into to try and win the iPod. Maybe one, right? But I think generally it was well done. And the questionnaire looked at self-report levels for operational stress, organizational stress, critical incident stress, and post-traumatic stress. And basically they were asked to report the likelihood of seeking help from a supervisor, a partner, a co-worker, a union representative, a base hospital educator, family, a therapist, and we kind of looked at partner, who you work with all the time, is different from a coworker who may be someone that you see at work, right? So, it was very interesting, when we kind of explored that where someone would go for help. I thought that was very interesting. Then we used stuff which I really don't understand. Maybe you can kind of touch on.
Sure. Well, we did a lot of math. I think is probably the.
I understand math. Anyway, this is like what's this qualitative kind of techniques or something, or is that?
They're quantitative techniques.
Right. See. Anyway, we used egghead type PhD analysis to assess these responses and put it in some type of mathematical quantification so that we could actually show the differences.
Absolutely. I think essentially what it boils down to is what we wanted to do is see, all right, can we find relationships that are statistically significant, or there is a greater than 95 or 99.9% chance that these relationships are not due to chance. What's a powerful predictor of stress? What isn't a powerful predictor of stress? And is there a difference in how people will seek help? So I think that for all of us who've been on the street for a while, yeah, you know that there are different things that cause stress. You know that there are different places you go for help, but we haven't actually tested that in a sort of statistically significant way, so it was worth it to ask the questions. So we had 145 paramedics answer the questionnaire, which is just over 50% of the service, so it's a respectable percentage of response. And we first looked at the relationship between stress and post-traumatic stress symptomatology in a bivariate way. What does that mean? That means you're looking at it just, what's the relationship between these two variables without any sort of other influences being considered. And so operational stress, so that's the stress associated just with being a paramedic, and post-traumatic stress had a statistically significant relationship. They had a reasonably high correlation, so there's a strong relationship. And P is less than 0.001, means there's a 99.99% chance that that relationship is not due to chance. Organizational stress had slightly lower correlation, but still pretty powerful. Also, critical incident stress and post-traumatic stress had a statistically significant relationship. So what does that all mean? That means essentially that they're related. They're related to each other, that there's a strength in the stress exposure and the stress reaction. We also looked at it in a multivariate way. What does that mean? That means that, you know, you can look at stress and stress reaction, but what is the impact of your level of training? Are ACPs more likely to be stressed out than PCPs? Are men more likely to be stressed out than women? Are people who've been on the service for 15 years more likely to be stressed out than people who've been on the service for 6 months? You know, what you do is you control for all that stuff. So saying everything being equal, you know, doesn't matter what your level of training is, your age, your gender, your length of service, any of that stuff, is there still a relationship? And so I'm going to show you a table that has a lot of numbers, so please forgive me.
Wow.
But essentially the important part is if you look at under Model 4, the two p-values that are highlighted in green, operational stress and critical incident stress times operational stress, are the significant predictors of post-traumatic stress symptomatology. So it says that, essentially what that says is your level of certification, your length of service, your age, your gender, the number of hours you work, your income, your ethnicity, all being equal. So it doesn't matter what any of those demographic characteristics are, there's still a significant relationship between operational stress and post-traumatic stress. There's also a significant relationship between critical incident stress. In a way, it interacts with operational stress. So if you have a high level of critical incident stress and you have a high level of operational stress, that increases your risk for post-traumatic stress. It's like a synergistic reaction. Remember synergy from like grade school? Mm-hmm. So it exacerbates a stress reaction. So really, the operational stress, that stress of doing the job, ends up being the most significant predictor of post-traumatic stress symptomatology rather than that critical incident stuff, or even the stress that's associated with, you know, cranky supervisors and lack of training and all that.
Yeah,
other
because
sort
that
of
one
stuff.
didn't vary out, right?
Yeah.
The organizational one, the boss one.
Yeah.
And the I guess they're doing a good job because it doesn't show that's
Wait.
actually.
In this model, it doesn't end up being a significant predictor. Now,
maybe some services it would be.
Definitely.
Yeah.
I mean, that is not to say that it's not a significant predictor. I'm just saying in this sample, at this time, that particular kind of stress didn't end up being a statistically significant predictor.
So people being made to sit on a corner in the middle of nowhere in the middle of the night and working the shift work and not getting their lunch and being standing up against the wall without a chair and all that stuff is affecting post-traumatic stress.
Absolutely.
And that may be modifiable, right?
Sure.
You know?
So when we think about how are we going to target stress, rather than thinking about the calls with, I mean, certainly the calls with kids and all that sort of stuff is important, but it's not the only thing we should be thinking about as far as managing post-traumatic stress reactions. So that was part of our study, and then the other part was looking at where are people going to go for help. And respondents were far more likely to seek support from a work partner than from anyone else.
That's awesome, eh? In some cases, it is their family.
Well, you're
right. It's their second.
Yeah.
It's their second husband or second wife.
Yeah.
and at the same time, and you think about it, and a paramedic work partner is the one who's going to understand. You don't have to explain why something's rough. You don't have to explain what you mean when you say, that someone coded or that, they already have the language of EMS, and so you already have that sort of shared synergy around this is why this is bad. So you're far more likely to go to a work partner than anyone else. And then sequentially, people were, beyond that, they were likely to go to a coworker, a therapist, a union representative, a supervisor, or a base hospital educator.
So you're at the bottom, really, right? It's like if you're really, really desperate and you really can't get help anywhere else, then talk to Bradford, I guess, right? This is kind of a message to me, right? Because I guess we're associated with maybe stress, right? Which is interesting, right? But I think the partner thing just shows me we got to look after each other. That's where maybe we've got to intervene, right?
Well, that's where it comes up where we live it together, right?
Yeah.
You're with this guy or girl for more than you are with your regular husband and wife, right, on a regular basis. So we live it.
That's what the military did, right? So that's why they looked at peer training, right? Because they found the same thing, that soldiers want to talk to another soldier, you know, and it's sort of interesting that independently, you know, this is sort of what we're looking at, right?
Yeah, and you think about it, you just think about your experiences, and you've certainly, I'm sure, heard people say stuff, and you're like, yeah, it sounds a little off, or, you know, there's something not quite right, or, you know, I can tell that that call is really still bugging them.
Yeah.
And so, you know, as someone who is present for it, hopefully you like your partner, just saying, hey, are you okay? And, you know, we're not expecting people to be counselors and therapists, but just checking in and saying, hey, you know, you don't seem quite right, or something's a little off, or, you know, do you need something, is a way to sort of provide a safety valve for folks that may be bottling it up, may be trying to suppress it, may not think it's okay to say, hey, I'm having a problem.
Mm-hmm.
So the key is to talk.
Yeah.
All right.
So, you know, what are the implications of some of this stuff? All right, well, a lot of times the only safety mechanism and the only way to go for help is an EAP. And the way you access an EAP or any sort of other counseling may vary from service to service, but oftentimes the way to get it is to go to a supervisor. And what our findings indicate is that you don't want to talk to the supervisor, and you certainly don't tell the supervisor that you're having a problem. And so that structural is a structural barrier that you have to getting access to services.
Why do you think that? Like, is it maybe because they don't want to show weakness?
I think you know, I think it's a very personal, private thing that's going on. And I think if you can go to the EAP and you can access your own counseling and through your benefit package or whatever, that's great. But if you're later now trying to link this to work, that, you know, you went to this event and that's when problems started to happen, then you really got to go through the WSIB process, which means you have to, you know, put down the day you were injured at work, right? And so bureaucracy of giving you support and giving you the appropriate care, you know, as an injured worker. If you think about an injured worker context, our whole model for that is, you know what, WSIB needs an injury date. They need to know who is looking after you, and they need to quantify how disabled you are, which means your supervisor then has a duty under legislation that they have got to provide that, right? They've got to put down that framework that we've identified our injured worker, we've got him or her the appropriate care that they need, and we've got some kind of modified work plan. Like, this is the problem. And I think that model, which maybe works in life, you know, and an injured back, maybe isn't the best level to have someone come forward and, first of all, even to say they're injured, you know, because there's a lot of social stigma attached to that, you know. And as we saw from the other structure, like, they're certainly not going to come to me and say I'm injured at work with my mental issue that I've had, you know, and with their supervisor. They don't really want to come out. And so you're looking at really two different pathways, right? One is I might go through the AP process and I'm issues at home or stress or whatever, and a lot of that may be from work, and that may be all private and personal. But if they want to get that quantified in order to go through a WSIB process or whatever, they have to kind of basically get to the point that they're willing to open up and tell the world, right? Because that's what it is, right? Your supervisors are going to know, your boss is going to know, WSIB is going to know, right? And that's, I think, a barrier for a lot of people until they get to a really bad level in their life that they finally have to do something. And sometimes what we're finding, and what I mentioned in the beginning, the preamble, is there's a change in performance at work. And sometimes it's when you're screwing up at work that we notice you need help, which is way too late. Because if you're screwing up at work, you're probably majorly screwing up at home, right? I mean, you're you know what I mean? Like, you're really at risk at that point, right? And that's the problem with, I think, the system with the way it's right now.
Okay, so I got a question that just came through from staff. It says, how open is WSIB to recognizing stress as a workplace injury? Do you know?
Well, it's actually on the Form 8, right? So, you know, you can put down, you can write down what the incident that happened, and you can document those things. And I know that WSIB has multimodality interventions that when you are injured, say if you have a back injury, you can't work and you get depressed, you may have to go on depression medications as a result. They're down with that, right? They send you to a center where you get worked on mentally, physically, you know, all of those pieces. So I think they've accepted that as a diagnosis, and they've accepted that as somewhere that they have to step in and provide care. I just think it's very difficult for the medic to come forward, and I think it's also difficult for the practitioners in the early phases to get a grip on the level of disability, for instance, right, or the modified work plan. Like, there's a lot of models that suggest putting person back to work as soon as possible is the best way to limit the disorders, right? Certainly in the military context, they really want to do this right up front so that you don't develop a lot of these maladaptive problems and disorder by having you confront the stress again, right? That old thing of get back on the horse, right? That type of thing.
So, and then just the second point on this slide, I just wanted to point out, we looked at people who were more or less likely to seek support from a supervisor, and perhaps unsurprisingly, those folks who wouldn't go to their supervisor, period, and stop, no way, were far more likely to be have levels of organizational and operational stress. So those people who aren't going to go for help to the people who can help them access services are the ones that are the most stressed out. So, not awesome. All right. So, I mean, essentially, we've already talked about a lot of this stuff. There's exposure to a lot of different kinds of stress can increase the risk for developing post-traumatic stress reaction. It's not just the critical incidents, it's not just the patient care, but it's a host of different kinds of stress that can cause someone to become impaired. Operational stress is probably the most dangerous kind of stress in this study, increasing a risk for post-traumatic stress reaction. But if you are stressed out because of the job and then you have a whole bunch of bad calls, that further exacerbates the risk. So they sort of pile on and can increase your risk for developing post-traumatic stress. So findings indicate that health and wellness initiatives should address both critical incident stress and chronic stress. We can't be blind to what is probably the most dangerous kind of stress, but we need to increase the scope so that we're addressing all of these sorts of stress. And also, we need to start thinking about how can we create outlets for people to get rid of some of the stress before they go into crisis and they end up coming to the attention of the base hospital because they're screwing up at work or they're having other sorts of major problems. Investments in awareness and education should be spent on peer programs, open houses with friends and family, rather than sending supervisors for extra training and stress identification. So, again, let's think more holistically about how we can address stress. Can we train paramedics to help take care of each other? Can we bring friends and family in a way so that you're not feeling so isolated, you're not feeling like, I'm not attending to my family responsibilities because I'm at work all the time. Those sorts of things potentially can help ameliorate some of that operational stress that's so problematic.
Yeah, maybe educate family members on what signs to look for and what, you're married to a person who does this kind of job and this is the kind of things that they'll be thrown in front of, and if you see this, they may need to get some help or something like that. I think that's kind of, an educational aspect of it, as opposed to, just taking that person that they're most likely to go to for help and really not using that as an opportunity, right, to deliver that, right? And I think, if you look at New Zealand, they have a critical incident, it's automatic that every paramedic that goes to that critical incident has to go through a debriefing, right? Which causes stress. Somebody, I don't really want to go, right? But in a way, it kind of takes off that whole pressure of having to self-identify, right? And going through it, it kind of educates everybody, and that's kind of a policy they have because people didn't come forward, right? And then it got too late, and then they ended up having PTSD, and then went on to commit suicide or whatever, right? So I think this is that's maybe we need to change our policy, right? When we look at policy change, right? And certainly that military context is what they kind of did. They adopted a similar model that you have to attend a critical incident stress debriefing. Right?
I'm actually not a big fan of mandatory debriefings. Mm-hmm. I think that for some people, talking about it can help. For some people, talking about it cannot help. So for some folks, the best thing is just to walk away, to go spend time with your family, to decompress in other ways. And so it's more a matter of can we create a lot of different outlets for folks so that the folks who want to go do a debriefing can do a debriefing. The people who don't want to go do a debriefing but want to access services in a different way can do it in a different way.
Yeah.
I think that mandatory debriefing potentially can re-traumatize someone if they're not ready to talk about something that's just happened. So
Yeah, that's a good point.
So it's one of those things that you really have to think more sort of holistically about, all right, what are all the other options that are potentially available? I think we had a couple other results. So some other thoughts we had. A thought should be given to create a way for people to access resources without having to go to supervisors, so that you don't have that sort of the structural barrier. And then further work needs to be done to remove cultural stigma associated with seeking assistance. So I don't think we're doing ourselves any favors by saying if you can't take it, then you don't belong here. It's not a nurturing message. It's not a useful message, and I think it can drive a lot of people out of profession who would otherwise be excellent care providers because they feel like they have to be strong and shut up. And so what that looks like, I think, will evolve over time. Part of the challenge is that people who are in supervisory positions often get there because they've been in EMS for 15, 20, 25, 30, 35, 40 years, and so they
You're old. Like, what do you mean?
No, I mean that they've
done every job.
They came up through EMS at a time where they you just didn't talk about your problems, and so why would they have experience or understand why it's important to talk about problems? Also, people who survive in the field typically have resilience, and so they don't need to talk about it the way someone who is newer to the profession that doesn't have that sort of skill set yet, they need to talk about it. So.
So I'll ask a question. It's $1 million question.
Okay.
If you want our families and whatever to help provide these, how do they get it? Where do they go and get that training? Who provides that training?
Well, that's what we're talking about. Like maybe some, if you look at there's like critical incident stress diffusing, right? Critical incident stress debriefing, which basically is educational intervention on these are the signs and symptoms that may happen to you, right? And maybe they need to get some education on that so that they can recognize, geez, she's yelling at the kids more than usual, right? Whatever, right? And maybe what happened, right? Maybe there's something going on at work because, you kind of get into a routine, right? I mean, you've been married a long time, and then suddenly there's a change in the behavior of your partner, your life partner, right? If you don't have that background and knowledge to understand that, then you may not put the link together, right? And so, having some workshops or something where that can be done, I don't think that's huge to do, right? But for something like a peer support program, I think that would be, a bit more, right, for the coworkers and that. And then what you need to have is a whole. Once you identify the peer support thing, you need to have a program. Is okay. We've identified this is an issue. I've got this. Where do I take this person, and what do I do with this person, right? And so those pieces all have to be in place as well, right? And in some way, we have an EAP program. We have this other program through the employer, right? So we have some of those pieces. But I think there's a barrier to accessing them due to the culture of being a paramedic. Right?
I think that there's certainly that if the paramedics start advocating and asking for these sorts of resources, hopefully administration will be supportive and willing to respond to that educational outreach seminars and bringing families in and talking about stress and talking about health and talking about this is the way that you can access help if you need it. And creating a sense of community really can help a lot. I think that as far as peer support programs, the ideal situation is one in which a service can develop a relationship with a mental health provider that can provide training on how to listen, basic counseling techniques, and then be there as a safety net so that if someone is over their head or they don't know what to do, they can go to this person and say, hey, I've got someone who's X, Y, and Z, and I don't know how to help them. So you've got that sort of other resource to ask for help.
I mean, if you look at the hospital thing, we have a child that's died. We work together and staff are upset and crying. I think at that point to create a permissive environment and say, This is just we do a debrief after code, how to went and when, you guys did a great job, and it's normal for us all to be affected by this